So then let's move on then to the lumbar spine. We've already discussed now myelopathy a couple of times, and it is possible to have lumbar spine myelopathy, and we're going to get into some myelopathy findings related to the lumbar spine in a bit when we get into discussion of gait. For now, let's talk about radiculopathy. In the AMA guides and in our own physical examination maneuvers, the important maneuvers for the lumbar spine are going to be focused on the presence or absence of radiculopathy. And I just want to quote again from the AMA guides on page 382, where it says that, quote, radiculopathy for the purpose of the guides is defined as, and here's another quote, another set of quotation marks, radiculopathy is a significant alteration in the function of a nerve root or nerve roots and is usually caused by pressure on one or several nerve roots, unquote. Not unquote. The AMA guides continue. They say the diagnosis requires a dermatomal distribution of pain, numbness, and or paresthesias in a dermatomal distribution. A root tension sign is usually positive. Let me pause right here. The guides tell us that the diagnosis of radiculopathy requires. What does requires mean? It means it requires, it's mandatory. It requires a dermatomal distribution of pain, numbness, and or paresthesias in a dermatomal distribution. Okay, those are sensory disturbances. Sensory disturbances are required. Next it says that a root tension sign is usually positive. I think it's therefore important that we consider the root tension signs in our physical exam. Finally, the guides continue by saying that the diagnosis of a herniated disc must be substantiated by an appropriate finding on an imaging study. Must be substantiated. However, the presence of findings on an imaging study in and of itself does not make the diagnosis of radiculopathy. There must also be clinical evidence as described above, and the clinical evidence that's described above is dermatomal distribution of pain, numbness, interparesthesias, and a positive root tension sign. So for our purposes here, the special tests that we'll be concerned with regarding the lumbar spine involve those tests that are instrumental for a determination of radiculopathy. We're going to be focused here on radiculopathy. So some of those tests include the heel-toe walk, include the repetitive squat maneuver, and the squatting maneuver is specifically described in the AMA guides. Then we'll get into root tension signs, some exam maneuvers that tension the L4 and L5 and S1 nerve roots, such as the straight leg raising maneuver, such as the Braggard's maneuver, such as the Slump Test, such as Nearies Bowstring sign, such as the crossed straight leg raising test, and then also for the L2, L3, and L4 nerve roots, the femoral nerve stretch test. Then we're going to turn our attention also to the lower extremity reflexes. Specifically, we'll talk about the hamstring reflex, which is an L5 mediated reflex. And then with regards to both radiculopathy and myelopathy, we're going to go into now a more extensive discussion of the gait evaluation. So let's begin now with a discussion of the heel and toe walk maneuver. And I want to go on record as saying that I love this maneuver. This maneuver is so functional and it gives you so much information, and I just love the way it plays out in the physical examination. Now, the heel and toe walk maneuver is specifically described in the AMA guides, and I've reprinted for you here Table 15.1, which describes what procedures are required in the physical examination of the lumbar spine. And for those of you that have the PowerPoint presentation, you'll notice at the bottom of the table it mentions muscle strength screening, including the heel and toe walk maneuver and the squatting maneuver. So we'll get into the squatting maneuver in just a couple minutes. But I want to spend some time now talking about the heel and toe walk maneuver. Now, of course, we do the heel and toe walk maneuver to assess the integrity of the L5 and S1 nerve roots, the two most commonly involved nerve roots with lumbar spine radiculopathy. Now, I have not reprinted for you here the entirety of Table 15.1, which includes the entirety of the lumbar spine examination. I simply have reprinted the upper portion of this table. But however, in Table 15.1, it goes on to discuss the other examination maneuvers that are required. And of course, in the neurologic examination, we're going to be doing manual muscle testing to assess the motor function of the lumbar spine nerve roots, including L5 and S1. Well, it's my contention and it's my opinion, and I'm going to take the position here now officially that the heel and toe walk maneuver is much more advantageous or efficacious, or it's much more telling, it's much more accurate than manual muscle testing, even of the same muscles. And I'm going to explain to you why, and I'm going to try to convince you to re-enamor yourself with the heel toe walk maneuver, because it just has so many functional applications. Now, the heel walking portion of the heel walk and toe walk maneuver requires dorsiflexion of the toes and the ankles. Now, dorsiflexion of the toes uses the extensor digitorum muscle, and extension of the ankle uses the tibialis anterior muscle. And both of these are reflections of the functions of the L5 nerve roots. So heel walking is L5. Toe walking requires plantar flexion of both the toes and the ankle. The toes are flexed by the flexor digitorum longus, and the ankle is flexed by the combination or the combined effect of the plantaris, the gastrocnemius, and the soleus, the so-called triceps surae. And toe walking is a reflection of function of the S1 nerve root. Okay, heel walking is L5, toe walking is S1. So, in order to assess the heel and toe walk maneuver, have the patient do extended duration contractions of these muscles in order to demonstrate full function. And a grading of 5, or a normal grade, would indicate the capacity to do 10 repetitions of both heel walking and toe walking. Okay? Now, in order to explain why it's important to include the heel walk and toe walk maneuver in your physical examination in preference to manual muscle testing of the same muscles, it requires a bit of explanation. And I want to go into a brief discussion about the lever systems of the body, at least as relates to heel walking and toe walking. So remember from physics or biomechanics, if you took biomechanics or kinesiology, that a lever is nothing more than a rigid body. And in the human body, levers are formed by bones, and muscles move the levers. Well, there's 3 different kinds of lever systems that we find in the body. We have a first-class lever, a second-class lever, and a third-class lever. And what these different leverage systems describe is simply various arrangements of the 3 components of a lever. There's 3 components to a lever. There's a fulcrum, there is an applied force, and there is a resisted force. So let me give you a couple examples to make this clear, and then I'll tie this into the heel walk and toe walk maneuver. With a second-class lever, say for example a wheelbarrow. A wheelbarrow is a second-class lever. It contains three components. It contains a fulcrum, which is the wheel, a resistive force, which is the load that's placed in the bucket of the wheelbarrow, and then the applied force that you, the laborer, apply to the handles of the wheelbarrow to move the load. Now, in a second-class lever, the load is placed close to the fulcrum, and the applied force that you, the laborer, apply is applied more distant from the fulcrum. So a second-class lever is a lever for which the applied force, and when we talk about the human body, we're going to talk about muscle forces. Muscles apply forces. So a second-class lever is a lever for which the muscle force and the resistive force act on the same side of the fulcrum, same side of the wheel of the wheelbarrow, with the muscle force acting through a moment arm that is longer than the moment arm through which the resistive force acts. And because the moment arm of the applied or muscle force is longer than the moment arm of the resistive force, this is a leverage system that has very advantageous mechanical advantage. Now, in the human body, when we find a second-class lever, due to its mechanical advantage, the muscle force required to lift the given load is much smaller than is the resistive force. Well, when we do the heel walk and toe walk maneuver, we're talking about a second-class lever system. The foot forms a second-class lever system, and so let's turn our attention here to the toe walk maneuver, which is actually nothing more than resisted ankle plantar flexion. What's the resistance? The resistance is the weight of the human body. So let's consider a person who weighs 200 pounds, just to use round numbers. For those of you that have the PowerPoint presentation, I'd like to have you refer to this diagram. Notice that the foot makes a second-class lever very similar to a wheelbarrow. The fulcrum, or the wheel of the wheelbarrow, is found at the metatarsal phalangeal joint. That's the pivot around which all the action of plantar flexion takes place, at the metatarsal phalangeal joint. The resistive force, which is the weight of the human body, is a force driving downward through the tibia bone, and the applied muscle force is an upward counteracting force that acts to lift the calcaneus. And so, like a wheelbarrow, the resistive force is closer to the fulcrum than is the applied force. So resisted ankle plantar flexion is a leverage system in the human body that has tremendous mechanical advantage. And that makes sense when you consider all the activities that we do that require us to elevate on our toes, and running and pivoting and twisting and climbing, and it makes sense that this would have to be a strong mechanically advantaged system. Well, when the body is raised around the metatarsal phalangeal joint, the point about which the foot rotates, or the fulcrum, is the ball of the foot. And because the moment arm of the applied muscle force is much greater than the moment arm of the resisted force, the applied muscle force required to raise the body is much less than the actual resistive force. So what kind of implications could this have for us in dealing with manual muscle testing? Let's say we want to do manual muscle testing of resisted ankle plantar flexion. Well, because of the mechanical advantage of this system and the strength of the triceps surae muscles, there's no way with resisted manual muscle testing that you're going to be able to apply enough force to overcome even a partially strong muscle. In other words, it takes tremendous amount of force to overcome the applied muscle force because of the mechanical advantage of this system. So That's what makes the toe walking maneuver so great. It allows the person to apply their entire body weight as the resistive force, which is much greater than you can apply, doctor, simply using the strength of your wrist and hands with manual muscle testing. Now, a third-class lever is a lever for which the muscle force and the resistive force act on the same side of the fulcrum, just like the second-class lever. However, in this case, the muscle force acts through a moment arm much shorter than that through which the resistive force acts. This would be sort of like a catapult. If you remember those old devices in the medieval days, that they would put a rock in this bucket and bend this long lever back, and the applied force would be at some point along the lever, but the rock is at the very end of the lever in a bucket. So the moment arm through which the resistive force acts is much longer than the moment arm through which the applied force acts. So in this situation, and with a third-class lever, the mechanical advantage is less than in the second-class lever. So therefore, the muscle force has to be greater than the resistive force in order to overcome the torque produced by the resistive force. So for those of you that have the PowerPoint demonstration, I have a diagram here of a third-class lever, which is the forearm, and the way that the bicep muscle acts on the forearm. So resisted elbow flexion, in other words, manual muscle testing of the biceps in the event of evaluating the C6 nerve root. With a third-class lever, the moment arm of the applied muscle force, which those of you that have the PowerPoint presentation, I'm outlining that here with my computer mouse. The moment arm through which the bicep muscle acts is much smaller than the moment arm through which the resistance force acts. So therefore, the bicep muscle is at a tremendous mechanical disadvantage in this situation. I mean, just look at the discrepancy in these moment arms here. Little tiny moment arm through which the bicep tendon acts versus a large moment arm through which the resistive force acts. So the applied muscle force, the force of the applied muscle, which is through the bicep muscle, must be much greater than the resistive force in order to overcome the inertia of that weight. And that explains why in the health club you can only do bicep curls with 30 or 40 or 50 pounds, but you can do standing calf raises with hundreds and hundreds of pounds because it's a different lever system. Now, with heel walking, the heel walking maneuver, the tibialis anterior muscle inserts onto the medial cuneiform bone and the base of the first metatarsal bone. And the associated muscles insert onto the middle and the distal phalanges, making the heel walk maneuver analogous to a third-class lever system. And so that's the beauty of the heel walk maneuver. In order to complete the heel walk maneuver requires tremendous amounts of muscle force. And the ability to perform the heel walk maneuver is good indication of preserved and intact function. In this case, we will be talking about the L5 nerve root. So I love the heel and toe walk maneuver for those reasons. They provide results that cannot be duplicated by other physical examination maneuvers. And you're going to want to see your examinee complete at least 10 repetitions, and that is 20 total steps, 10 on each side, 10 steps of heel walking, 10 steps of toe walking on each foot, and that would result in a grading of 5 or normal. And therefore, if your examinee is able to complete the heel walk and toe walk maneuver, that's a sign of preserved and intact function of those muscles and the associated nerve roots being L5 and S1. So if that's the case, what would you expect to find later on in the manual muscle testing if you were to repeat these maneuvers of resisted ankle and toe dorsiflexion and resisted ankle and toe plantar flexion? If your examinee was then to go weak during manual muscle testing, that would be considered a non-physiologic exam finding. So here we have a case where we have duplicative maneuvers that should be consistent throughout. The AMA guides also describe the repetitive squat maneuver, and we're going to see the same pattern repeated here as we saw with the heel and toe walk maneuver, and that is the repetitive squat maneuver gives us a maneuver, a functional maneuver that requires good strength and good function of the entire lumbar spine and the entire lower extremities, which should be verifiable and should be consistent throughout the remainder of the physical examination. And the repetitive squat maneuver is specifically described in Table 15.1 of the AMA guides, which I've reprinted here for you on your PowerPoint presentation. So how do you do it? Well, have your examinee squat down and repeat for 5 or more repetitions. And doctor, it helps if you do it with them. I do this with my examinee, and I do this in order to show them that the repetitive squat maneuver should be really no big deal. Unless there's some sort of reason that would prevent repetitive squat, such as a lumbar spine pathology, a knee pathology, etc. In general, the examinee should be able to complete 5 to 10 body weight repetitions of the repetitive squat maneuver, and I indicate that to them by performing them side by side with them. So let's think about it. If your examinee is able to complete 5 repetitive squats, what does that indicate? Well, it indicates preserved and intact function of a lot of structures associated with the lumbar spine, a lot of structures associated with the lower extremities. For example, what would the repetitive squat maneuver tell you about the function of the quadricep muscles? What would it tell you? It would tell you that the quadriceps are preserved, correct? What would it tell you about the function of the gastrocnemius muscles? It would tell you that the function is preserved. If the person is able to come off the ground and extend plantar flex at the ankle, thereby extending the tibia, it tells you that the function is preserved, correct? If they're able to do it without falling over or losing their balance, that's an indication of preserved sensory function of the lower extremities, correct? So I really like the repetitive squat maneuver. And later on in the examination procedure, when you perform manual muscle testing, for example, on the quadricep muscles, those quadricep muscles should test strong. And if they don't test strong, that would be considered an inconsistent exam finding, inconsistent with the ability to perform the repetitive squat maneuver. Okay, let's go on to the root tension signs now. And before we get into root tension signs, there's a couple warnings and a couple of heads up about root tension signs. And that is that these tests were designed and interpreted originally as tests of involvement of irritability of the lumbar spine nerve roots by assessing for reproduction of symptoms when the nerve roots are tensed. So that's what these maneuvers are designed to do, is to tense the nerve roots. But we need to remember that the spinal nerve roots are not the only structures that are provoked by these tests, and different tests will provoke different structures. So some of the additional structures that are provoked by these tests would include the vertebral facets, possibly the sacroiliac joints, possibly the hip joints, possibly the hamstring muscles, possibly the connective tissues and fascial elements, and And a lot of different tissues are put under stress by these maneuvers, not just the lumbar spine nerve roots. So you need to be aware that one of these other structures may be the source of symptoms or may contribute to the overall constellation of symptoms. So you need to properly assess all of these structures before you can conclude which structure it is that's responsible for their report of pain. Okay, so let's talk about, first of all, the straight leg raising test. The straight leg raising test can be done both supine and sitting. And to do the supine straight leg raising test, the subject lies supine with the non-test limb positioned in extension and resting on the table. Then you, the examiner, passively raises the test lower limb, and make sure that your examinee is completely relaxed and that movement of the lower limb is passive, meaning that you as the doctor lift the entirety of the weight of the lower limb. Make sure to keep the hips slightly abducted and slightly internally rotated and the knee fully extended. The angle of the hip measured between the elevated lower limb and the table is recorded as your measurement of straight leg raising angle. Now, reproduction of symptoms in the back or along the distribution of the sciatic nerve indicates a positive test. Now, according to some studies, and I'll tell you what the AMA guides say here in just a minute, the sciatic nerve is on its full stretch, maximum tension at approximately 70 degrees of hip flexion. Therefore, a positive test for sciatic nerve involvement will occur prior to that amount of hip flexion. And how many times have you had examinees who are able to complete 85 degrees of straight leg raising before they report a reproduction of symptoms? That would be considered unrelated to nerve root tension, perhaps related to some of those other structures that we talked about, such as the connective tissues, the fascia, the hamstring muscles, etc. Okay, so positive findings for straight leg raise testing include a report of lower back pain and or report of pain down the back of the leg in the distribution of the sciatic nerve. So for those of you that have the PowerPoint, I have a diagram here that indicates that the greatest tension on the nerve is between 20 and 70 degrees of hip flexion angle. Now, pain with straight leg raising, as we said, can come from the muscles, can come from ischial can come from hamstring tightness, can come from a variety of structures. So how is it that we can begin to determine which actually is the pain producer? What is the pain productive tissue? Well, let's go through a couple procedures and start sorting out which tissues are responsible for pain. The guides say on page 376 that research indicates that the maximum movement of nerve roots occurs when the leg is at an angle of 20 degrees to 70 degrees relative to the trunk. However, this may vary depending on the individual's anatomy. Further, the L4, L5, and S1 nerve roots are those that primarily change their length when straight leg raising is performed. Thus, pathology at higher levels of the lumbar spine is often associated with a negative straight leg raise. So in order to help sort out some of the possible pain contributors, we have a variety of tests to help us. The first of which is the popliteal compression test. So the purpose of the popliteal compression test is to help us determine if indeed it is the lumbar spine nerve roots that is a source of pain, or is the pain coming perhaps from the facets or from some other structures? So to use the popliteal compression test, what we do is we perform a straight leg raising maneuver, and we elevate the test limb up to a point at which the examinee reports sciatic nerve pain. And like we said earlier, that should be somewhere between 20 and 70 degrees of hip flexion. Then what you do is you lower the involved leg a few degrees below the point at which the examinee reported the symptoms. And what's the purpose of lowering the leg a few degrees? The purpose of lowering the leg a few degrees is to take tension off of those other structures. For example, lowering the leg a few degrees removes tension from the hamstring muscles. It removes tension from the connective tissue muscles. It reduces loading on lumbar spine facets. It reduces tension on the hip joint capsule, etc. So once we've reduced the tension below the point at which the examinee reports symptoms, then we want to perform the compression maneuver to stretch the lumbar spine nerve roots to assess for reproduction of pain. So what we do is we apply compression with our thumbs to the popliteal fossa, thereby tractioning the sciatic nerve at its bifurcation. And in the presence of irritation of the nerve roots, this should provoke symptoms with a lesser degree of hip flexion angle than does the straight leg raise maneuver. So the popliteal compression test is a confirmatory maneuver to confirm the cause of the pain as being due to the lumbar spine nerve roots. Another maneuver that we can use is called Braggard's maneuver, also known as the sciatic stretch test. And similar to the popliteal compression test, your subject lies supine, and again you raise the test limb up to the point at where your examinee reports sciatic nerve distribution of pain, and then you lower the limb just a couple degrees below that point of pain, and the pain will either resolve or the examinee will say that it's significantly less. And then, like the popliteal compression maneuver, you stretch the lumbar spine nerve roots by dorsiflexing the ankle, and that tractions and pulls on those peripheral nerves up to the sciatic nerve, and then from the sciatic nerve up into the lumbar spine, further tractioning those irritated nerve roots. And in the event of irritation of the lumbar spine nerve roots, this should provoke pain. Now, with dorsiflexing the ankle, you are going to be tightening the calf muscles, and your examinee may report calf muscle tightness. That would be considered a normal finding and would have to be distinguished from sciatic nerve distribution of pain below the knee. So with Braggard's maneuver, the result is positive if symptoms are reproduced in the lower back or in the involved lower extremity, especially down into the calf and foot. Now, imagine your examinee reports radiculopathy symptoms with the application of Braggard's maneuver. If you were the examinee and you had your ankle dorsiflexed, provoking sharp sciatic nerve pain, how would you respond? Do you think there might be some sort of reflexive action to reduce tension on those irritated nerve roots? Well, it turns out that there is. In the event of a sharp reproduction of sciatic nerve pain, you would expect to see your examinee reflexively flex the knee, or reflexively plantar flex the ankle. If dorsiflexion reproduces symptoms, they may reflexively plantar flex their ankle in order to relieve the tension on the nerve roots, or they may reflexively flex the knee in order to reduce traction on the lumbar spine nerve roots. And a validity maneuver that you can do as the doctor excuse me, is when your examinee reports an increase of pain with the Braggard's maneuver, you simply then take the ankle in the other direction toward plantar flexion to reduce the traction on the lumbar spine nerve roots, and this should relieve the symptoms. Now, your examinee does not know that this should relieve the symptoms because they're not doctors, and in the event of a positive report of lower back or lower extremity pain symptoms, this would constitute a non-physiologic exam finding and may raise your suspicion for symptom magnification. So I love most of these maneuvers because they have built-in validations, and they have cross consistency with other examination maneuvers as well. Another maneuver that we use is the crossed straight leg raising test. And when we use the term crossed straight leg, we're talking about the opposite uninvolved lower extremity. With the cross straight leg raising test, the subject lies supine while the examiner passively performs a straight leg raise of the uninvolved lower limb. And the result is positive if pain is reproduced in the back or in the involved limb. And a positive test is usually representative of some space-occupying lesion, such as a central disc herniation. Again, in the event of a positive report of pain, you might expect to see some sort of reflexive action by the examinee, the purpose of which is to reduce the tension on the lumbar spine nerve roots. The slump test is another good sciatic nerve tension test. Pulls the sciatic nerve and dural structures from above as well as from below, whereas the straight leg raise test pulls simply from below. And this might be a variation maneuver that you may use as a progression along your radiculopathy test. For example, if the straight leg raising test is negative, you may then proceed to the slump test, which basically is like a straight leg raise testing, but it adds additional traction on the dural structures from above as well as below. So to perform the slump test, the subject is seated. They have their upper limbs clasped at the hands behind their back. And then the subject is asked to slump forward at the trunk. And by slump we mean they flex their chin to their neck, and they round their shoulders, and they flex the thoracic spine, and they basically slump forward, thereby tractioning the spinal cord and dural structures. Then you, as the examiner, using one arm, you next apply overpressure through the shoulders to the slump trunk, further stretching the dural structures. The examiner then directs the subject to forward bend the neck, after which the examiner again applies an overpressure. With this overpressure being maintained by the examiner at the head, neck, and trunk, the subject themselves then extends the knee, and then the ankle is dorsiflexed by you, the examiner. And doctors, you might just try and reproduce this movement here at your desk or in your chair, wherever you are. Slump forward, bring your chin to your chest, round your shoulders, flex your thoracic spine, extend your knee, and then dorsiflex your ankle. And you can feel the tension throughout the dural structures, up the leg, the fascial structures up the leg, the dural structures in the lower part of the spine, and even all the way up into the neck. And this is an advanced and aggressive maneuver. So you might consider this as a progression along your nerve root tension testing. So here's a diagram for those of you that have the PowerPoint, which shows basically this examinee is doing a straight leg raise test, and you can see that he's in approximately 70 to 80 degrees of hip flexion. Okay, so that would be like near maximum tension on the sciatic nerve. And then the examiner is further tensioning the dural structures from above by applying overpressure to the head, neck, and shoulders, and then from below by dorsiflexing at the ankle. So this is a maneuver that you would want to approach very cautiously, and in the presence of positive findings on some of your other root tension tests, such as straight leg raise and Braggard's test, this is a maneuver that you might not even find to be necessary. Finally, with regards to root tension signs of the L4, L5, and S1 nerve roots, we have one more maneuver, which is actually not really a maneuver, but it's more of an observation. And I love this concept. This is called Nearies bowstring sign, or sometimes referred to just simply as the bowstring sign. And before we talk about it, just consider for a moment what would happen if you yourself had a hot sciatic nerve, or you had a hot L5 nerve root. And every time you flexed at the hip and dorsiflexed at the ankle, you got a sharp electric-like shooting pain down the back of your leg. What would you do? How would you act? How would you accommodate or adapt your movements so as to prevent this disturbing and distressing noxious pain? Well, that's the bowstring sign. The bowstring sign is an observation of flexion of the knee on the involved side as the hip flexion angle increases. And you'll observe this sign whether the examinee is either standing or supine, because as nerve root tension increases and pain increases, there's a reflexive flexion of the knee in order to relieve that pain and that tension. And many times this is involuntary in an effort to relieve tension on the root, and it's an adaptive, accommodative behavior. It's reflexive. So how would the Nearies bowstring sign manifest itself throughout the course of physical exam? Well, sometimes this can be detected as an inability to perform the heel walk maneuver, because recall the heel walk maneuver requires strong dorsiflexion at the ankle, similar to performing a Braggard's maneuver. That would be evidence of a hot radiculopathy, because with the heel walk maneuver there is no hip flexion angle. The hip flexion angle is 0, but there is strong dorsiflexion at the ankle, which could provoke nerve root symptoms. How else would it present? How about with straight leg raising maneuvers? Here you see an examinee getting the straight leg raise maneuver. In the event of hot L5 nerve root, you would expect her to see her flex her knee as a reflexive protective response to pain. Okay, so when your examinee reports positive symptoms with these root tension tests, you're going to want to look for the reflexive bowstring sign. And absence of a reflexive bowstring sign may be considered a non-physiologic exam finding. And one of the ways that the bowstring sign shows up is in the lumbar spine range of motion maneuvers. And recall, with the AMA guides require that we take our examinee through some warm-up maneuvers prior to measuring the range of motion with goniometers. So as the examinee goes through various warm-up maneuvers, particularly lumbar spine flexion, which involves both hip flexion and a dorsiflexed ankle. In the case of a bona fide radiculopathy, you would expect to see some degree of reflex flexion of the knee. Okay? So if you don't see a positive bowstring sign with lumbar spine range of motion standing, but the examinee does report pain with straight leg raising test, those findings would be inconsistent and may raise your suspicion for symptom magnification. And then finally, we have a root tension sign also for the L2, L3, and L4 nerve roots, and that is the femoral nerve stretch test. Now, the femoral nerve stretch test is used to determine whether there's any irritation of either the femoral nerve or the nerve roots of L2, L3, and L4. And recall that both the femoral nerve and the obturator nerves are composed of L2, L3, and L4 nerve fibers. So to perform the femoral nerve stretch test, the subject is prone. The examiner flexes the subject's knee while supporting the thigh just proximal to the knee. Okay, so your subject is prone. You grab the thigh just above the knee and you flex the knee. So the knee is at approximately 90 degrees of knee flexion. The examiner then stabilizes the pelvis and extends the thigh at the hip to provide a stretch of the femoral nerve. And recall that the femoral nerve crosses the hip joint as it comes off the psoas muscle and leaves the pelvis and enters the leg. It crosses the hip joint to enter the thigh, and so extension at the thigh with flexion at the knee. And the purpose of flexion of the knee is to further tension the anterior structures of the thigh, including the quadricep muscle, the rectus femoris muscle, and the femoral nerve and their nerve roots. So in the case of radiculopathy of any of those nerve roots, the positive finding would be pain either reproduced or exacerbated in the back, or throughout the distribution of the femoral nerve would be considered a positive finding. So let's think about this a minute. Let's say, for example, the subject did have a hot L4 nerve root due to disc prolapse. And let's say that stretching the femoral nerve with the femoral nerve stretch test produced a report of increased pain both in the back and in the thigh. What type of reflexive objective exam finding would you expect to accompany a positive report of pain? What would you expect? Well, you would expect some type of reflexive action, the purpose of which would be to reduce the traction on those nerve roots. So the subject may reflexively and forcibly extend their knee, or they may reflexively and forcibly flex their hip in order to reduce tension on those nerve roots. So I like these maneuvers, and you need to think on both sides of the maneuvers. In other words, what is a positive finding indicate, and what associated maneuvers and positions would you expect to relieve such findings in the event of a bona fide radiculopathy. Finally, as we wrap up this section on lumbar spine radiculopathy, I just want to take a minute and touch upon an interesting subject. The AMA guides in Table 15.2 describe the common radicular syndromes that we see in the lumbar spine. And let me just ask you, doctor, what are the common reflexes that you test in the lower extremities? Now, 99.9% of doctors will answer that they test the patellar reflex to assess for the integrity of the L4 nerve root, and 99.9% of doctors will tell you that they test the ankle jerk reflex to test the integrity of the S1 nerve root. Well, most doctors do not do any type of reflex testing for the L5 nerve root, but the AMA guides describe the medial hamstrings reflex as associated with the L5 nerve root. Now, there's actually two hamstring reflexes because we have both the medial and lateral hamstrings. The medial hamstrings are composed of the semimembranosus and semitendinosus tendons. That's where we test. And the lateral hamstrings are composed of the long and short heads of the biceps femoris muscles. Now, both the medial and lateral hamstring reflexes are mediated by the L5 nerve root. Both mediated by the L5 nerve root. And it's elicited, these reflexes are elicited by tapping the hamstring tendons at the musculotendinous junction near the back of the medial or the lateral knee, depending upon which reflex you're testing. Now, the AMA guides describe testing of the medial hamstrings, but I'm telling you there are reflexes in both hamstrings. Now, the medial hamstring reflex is mediated by the L5 nerve root that is carried in the tibial nerve, while the lateral hamstring reflex is mediated by the L5 nerve root that's carried in the common peroneal nerve. So both reflexes, you can use either of the reflex to assess for integrity of the L5 nerve root. However, in the event of a peripheral nerve injury, and sciatic nerve injuries more commonly, 6-to-1 that is, involve the common peroneal division of the nerve versus the tibial division of the nerve. So in the case of a peripheral nerve, this distinction in the reflex may become significant. For example, if the medial hamstring reflex is preserved, but the lateral hamstring reflex is diminished or absent, that would be indicative of an injury to the common peroneal division of the sciatic nerve, and vice versa. So the AMA guides don't talk about that. They simply talk about testing the hamstring reflex to assess for integrity of the L5 nerve root. And Doctor, I encourage you to practice your testing of the L5 reflex, because many doctors don't test this one because they either haven't learned it or they have not been successful at eliciting the reflex. So the important component of eliciting the reflex is to find the musculotendinous junction of the medial hamstrings, and that's located approximately 4 finger breadths above the knee. And you can palpate that and feel that yourself by sticking your fingertips underneath your thigh and contracting your medial hamstring muscles, and you'll feel the musculotendinous junction about 4 finger breadths above the knee. Okay, so let's move on now and go into some discussion of gait and wrap up the physical exam section. And looks like we're right on time, and we'll have plenty of time for some radiographic special tests as we take a look at the topics of analysis of motion segment integrity and compression fractures.